So we'd like to move on to adjuvant therapy. And Evan, so do you have a preference of adjuvant over neoadjuvant therapy, and why?
I absolutely have a preference. I definitely prefer neoadjuvant whenever possible. And the best level 1 evidence is in the neoadjuvant setting. There have been multiple adjuvant trials in the older days, multiple small adjuvant trials with mixed results, but there were multiple issues with those trials, reporting issues, statistical flaws. There was a nice meta-analysis done that did seem to show a benefit to adjuvant therapy. But that being said and done, that doesn't replace level 1 evidence from a randomized controlled trial. Now, in more recent years, there have been 3 attempts at large randomized controlled trials, EORTC, the Spanish trial, and an Italian trial. And unfortunately, none of them fully accrued. And we've seen some mixed results in those studies as well. But again, I think the key situation is whenever you can give it, you should try to give it in a neoadjuvant fashion. Of course, we do run into situations where the patient comes to our clinic and they've already had cystectomy, they've already had their surgical procedure. Then what do you do? Well, I think those situations can be challenging, but I think it's most important to look at patient fitness, comorbidities, et cetera. And the reason is that one could extrapolate from the preoperative setting and say, has the biology really changed from the preoperative setting to the postoperative setting? Well, probably not, but there are a few things that are different that make me really prefer neoadjuvant chemotherapy. For instance, number 1, the patient's going to tolerate it better when they're receiving neoadjuvant chemotherapy than after they've undergone a major surgery and now they're going to receive adjuvant therapy. The other thing is that when you undergo neoadjuvant chemotherapy, there's really a great marker, a biomarker of response, and that's, you alluded to that earlier with the PT0 rate. A complete response in the SWOG trial, the neoadjuvant SWOG trial, really conferred that the patients with a complete response to neoadjuvant chemotherapy had way better outcomes. We cured the vast majority of those patients. And so that's important information and data to learn from. And so again, I would say that in any opportunity possible, I'd give it in the neoadjuvant setting. If I don't have the choice or opportunity to intervene or make that decision, then I really take it on a case-by-case basis with the patient.
What's your time frame? What's the optimal time that you'd like to administer your chemotherapy in these patients?
Yeah. I think that's not 100% clear in the adjuvant setting when to administer chemotherapy. I do think sooner is better than later. Certainly, I wouldn't administer it within the first month after surgery. The patient has to be recovered from the surgery, but there is some data that shows that if you want to administer chemotherapy, that sooner is probably better. Certainly within a 6-month time frame makes sense, and that's what I would certainly target.
I've seen some people say after 2 months, don't bother with adjuvant therapy. Dean, is that what your institution?
Yeah, we will generally think, we try to do it or try to start it within 12 weeks of the surgical procedure. And I typically try to target around 6 to 8 weeks. But Evan makes a really good point. This is major surgery. It's major surgery in an older patient population. And so trying to start chemotherapy quickly in somebody who's still recovering surgically is difficult. And if you start too early, you may get the first couple doses in, but you can't get the entire course in. And that's what we all worry about. This setting is crying for non-toxic therapy that's beneficial, for patients.
Exactly. I think this is really an area where some of the newer immune therapy treatments should move in, because certainly we're seeing, and we'll talk a little bit about this later, we're seeing activity, but there are now trials that are being designed to look at some of the checkpoint inhibitors adjuvantly afterwards, and I think that's a really interesting area.
I'll just bring up, there actually is an immunotherapy trial that's been performed in the adjuvant setting, and that was basically targeting HER2/neu. It was using an active cellular immunotherapy similar to Sapilocel T in prostate cancer, but targeting HER2/neu in bladder cancer. And it was also in this adjuvant setting for either patients who underwent neoadjuvant chemotherapy and did not have a complete response. We know those patients have a worse prognosis, or for patients who didn't undergo neoadjuvant chemotherapy. And that basically allowed patients to receive this autologous cellular immunotherapy, again, 3 doses, similar to Sapilocel T in prostate cancer. And what we've seen early data from that is that immune biomarkers have shown and very similar to prostate cancer in the fact that there's been a CD54 upregulation, which is a marker of an activated antigen-presenting cell. There's been humoral responses with antibodies against the target, which is HER2/neu in this instance. And so that data exists out there, but we have to wait for the mature survival data down the road.
And certainly I think it's an interesting approach because if we see the analogy as to what happened with prostate cancer, where you started seeing an antigen spread after a period of time where multiple antigens were now had either antibodies or cellular-based immune effects. This, I think, could be certainly a very, very powerful tool in taking care of patients. And then, of course, identifying other antigens would be interesting from that standpoint to generalize it more. As we know, HER2/neu is only expressed in about 20 to 30% of bladder cancer specimens. There's some controversy as to whether it actually marks for a poorer prognosis. I think probably the best study that looked at that in metastatic disease was Maha Hussein's study looking at a triplet chemotherapy regimen along with Herceptin. And she did note that there were higher levels of volume of disease in those patients who actually were HER2 positive. So I think that this is a very interesting approach and certainly could be useful in the future.
Yeah, one thing I'll bring up, and again, Dr. Bajorin is probably the best person to talk about this because I believe that was your study as well.
It is.
So.
It is.
So, but anyhow, please correct me if I make any mistakes, but I believe in this trial targeting HER2/neu with active cellular immunotherapy, they only needed 1+ HER2 staining, and the thought is that, again, you're going to get an immune response and potentially have some bystander effect with neighboring cells being targeted as well down the road and antigen spread, as you mentioned earlier. I believe if you use that 1+ criteria, it was about 60 to 70% of the patients. Is that right?
Yeah, so that's a really good point. And so I think, for the audience, when we look at HER2, for example, we're looking at different aspects of the biology. In Maha's study, it was with trastuzumab. So it's really looking at, HER2 as a functional, molecule. In this instance, it's looking at this molecule as a target for immunotherapy. So you're down into very low levels of expression, but all you need is a little bit of expression to be an antigen for immunotherapeutic response. And so that's exactly what was seen, was a high level of expression, but it's really not functional. And so hopefully, the approach will at least allow us to look at antigens across the board. As you know, for example, the checkpoint blockade, people are looking for neoantigens, et cetera, and I think that that's where we may be very shortly.